Welcome to another episode of Syndromic Insights podcast, brought to you by the World Society for Pediatric Infectious Diseases. We're your hosts, Dr. Linny Phuong.
And I'm Dr. Alicia Chang. In this episode, we are exploring gastrointestinal infections and first-line syndromic testing.
To shed some light in current practices in gastrointestinal infections, I spoke to Dr. Hyun Mi Kang, Associate Professor at the Department of Pediatrics at Seoul St. Mary's Hospital in South Korea. I really enjoyed this discussion and learning, which centered around two very different cases. This episode highlights the value of syndromic testing and being able to test for bacteria, viruses, and parasites, which are extremely relevant in gastrointestinal presentations.
Also, don't forget we want you listening at home to take notes and consider how you would manage these cases along with us. Let's check out your conversation with Dr. Kang and report back to each other, Linny.
Welcome to the podcast, Dr. Kang. Thank you for having us.
Thank you very much. It's a pleasure to be here.
Thank you. Before we get started, I'm going to read out your bio because, as with our esteemed guests, you are quite an impressive individual. So for our listeners, Dr. Kang graduated from Seoul National University Medical School and went on to a pediatric infectious disease fellowship at Seoul National University Children's Hospital. She's currently working as a pediatric ID specialist and associate professor at Seoul St. Mary's Hospital, the Catholic University of Korea. Dr. Kang is a board member of the Korean Pediatric Infectious Diseases Society, and her major research interests are threefold: molecular epidemiology and the whole genome sequencing of virulence factors of bacterial pathogens, antibiotic resistance and stewardship, and vaccine safety and immunogenicity.
Right, thank you very much for the introduction.
Oh, pleasure. Thank you for joining us. So today what we'll be doing is we're going to discuss gastrointestinal infections and why first-line syndromic testing is so helpful in these sorts of infections. So before we dive in, Dr. Kang, do you want to just tell us a little bit about the platform that you're using in your hospital?
Sure. So at our hospital, we do also use the current conventional methods such as culture-based methods or microscopic exams, but we've also moved to using the GI syndromic panel. And the panel that we use at our hospital is a nested film array panel. And so the turnover time is quite fast. It's actually 1 hour for the test. So from specimen collection to the result time, you would need about 2 to 4 hours until the results are reported. And this panel includes a variety of pathogens. It also includes the most common pathogens of childhood gastrointestinal infection pathogens, such as Campylobacter, Salmonella. It also includes viruses such as adenovirus, norovirus, and rotavirus. And it also includes the diarrheagenic E. coli, so, STEC or EPEC and such. And it also includes some parasites that we can see rarely in the clinical setting.
What kind of parasites does it pick up on?
Okay, so it includes the Entamoeba histolytica, the Cryptosporidium, Giardia lamblia, and etc.
Okay, so all the things that essentially we would pick up on culture-based methods as well, and perhaps we could see under a microscope, but with a very quick turnaround time, as you said.
Yes, that is correct.
Yeah. Okay. And so how does that help in terms of your workflow? So if you have a patient that you've admitted with a gastrointestinal infection, I'm assuming you do the test, you put them on the ward, put them in perhaps some form of isolation, and then wait for a test result, or what's the process there?
Okay, so for admitted patients, that would be our process. But currently, most of our patients are being admitted through the emergency room. And so in that case, we would select the patients that would be the most appropriate or have the most benefit in these syndromic panels. So we would undergo the testing at the emergency department first. And because it has a rapid turnaround time, we would receive the results prior to admission so that when we admit the patients, we can determine if they need isolation or if they need antibiotics. etc.
That's extremely helpful. I'm sure it's sort of it helps with both of those aspects, where to place the patient, but also, yes, whether or not to start antibiotics it's always a good
That's right.
question. No, that's great. And so let's go into our first case. So we're going to be hearing about the story of Jay, and just for clarity for everyone, we are not using any real names or personal details in this podcast. So to hear Jay's story, we have Jay, who is a previously well 6-year-old girl who suddenly develops abdominal pain and within a few hours develops a fever. We're told that a couple of days later, she then develops diarrhea and her temperature continues to rise above 39 degrees. Her parents take her to a local clinic where she is prescribed analgesia, including an antispasmodic agent to settle her abdominal pain, and is also recommended antipyretics for her fever. So despite all of this, her abdominal pain and her fever persists, and she arrives in the emergency room 5 days after her initial symptoms begin. So I guess what we'd like is for people listening to imagine that they're on this evening shift and think about what conditions they would like to exclude and perhaps what information that they need from the parents. So Dr. Kang, I'm going to turn to you now, and if you're able to talk us through perhaps how you proceeded with this case.
All right. Okay, so when the patient arrived at our emergency department, it was day 5 of her high fever, and she was very ill looking and dehydrated and had abdominal pain. So we really needed to find her fever focus and, differentiate if it was surgical abdomen or it could be treated medically. And we definitely wanted to intervene before her condition worsened. So first we did a thorough history taking, and we asked the parents about the frequency and consistency of her diarrhea. And they had explained that it was very watery, some in large amounts, especially after eating, and in between meals, just tiny amounts of diarrhea, with a total of 6 to 10 times a day for the first 3 days. But on the day prior to her visit to our emergency department, she was barely eating and drinking fluids, and her diarrhea frequency decreased to 1 to 2 times a day. But at this point, it became mucoid, and they said that she began having bloody stool or hematochezia.
Okay.
So we then carried out
so-
a physical exam, and she showed that she had periumbilical and left lower quadrant tenderness, but she didn't have any guarding or no rebound tenderness, especially at the right lower quadrant, which is, where we needed to think about for surgical abdomen. So at
And was
this
she still
point,
febrile at this point?
yes, she was still
still
febrile
febrile?
at this point. That's correct.
Okay. And so I'm assuming then you moved on to some investigations.
That's correct. So at this point, just with her history and physical examination, we were suspicious of acute gastroenteritis. And then we wanted to, look for the source to see, where she had contracted this virus or bacteria or whatever it was causing her upset GI tract. So we asked whether she had any travel history or of the foods that she ate. And the parents had said that they don't remember anything in particular. However, about 2 to 3 days prior to her symptoms, she did have takeout food that was delivered from a restaurant, but she didn't want to, she wasn't feeling hungry. So after about 2 hours after delivery, after it was sitting out, just on the table, she then ate it. However, mom and dad both ate it right away, so they weren't having the same symptoms.
So maybe that was the source, maybe.
That's right. We're not sure, but that's
Maybe.
maybe that's correct.
Yeah, of
And
course.
so,
And so what did you find in terms of her investigations?
okay, so because she was considered moderate to severe in terms of her diarrhea and dehydration, we did a complete blood cell count. We checked her CRP levels. We did a blood culture and stool exam, which consisted of stool cultures plus the GI mesothelin array, syndromic panel that we have at our hospital. And we found that her white blood cells were quite elevated. Her CRP levels were extremely high. And so at this point, we wanted to, just in case she had bacterial gastroenteritis that needed intervention immediately, we began her on IV third generation cephalosporin and waited until her blood culture results came out. But The syndromic panel at our hospital, after we collected our specimen and turned it into the lab, after 3 hours, we got back the results and it was positive for
Mm.
salmonella in her stool.
Oh, wow. Okay, there we go. So it was quick.
That's right.
So this you were saying in the stool or in the blood?
So this was in her stool, but
In the
we
stool,
also
okay.
did perform blood cultures, and we were waiting for her results for that. But we knew immediately that she had salmonellosis, and so we began her on antibiotics, and then we were planning to admit her to see whether her blood culture results would come back positive for salmonella as well.
And what did that show?
All right, so one day after, about 24 hours after, we had already received her results for the syndromic panel, which showed positive for salmonella. Her blood culture results also reported positive for salmonella in her blood. And so we waited further for her antibiotic susceptibility testing results, and then we
Yeah.
were able to, step down and use ampicillin, which showed susceptibility.
Oh, fantastic. So you were able to step her down to orals, and by then she was hopefully feeling better and closer to going
Yes,
home.
that's right. That's
Yeah.
correct.
Oh, that sounds like there was a good outcome. And so diagnostically, what do you think were the challenges within this case, if any?
Okay, so I think just the challenges were that prior to getting her results back, we were having to think about the different causes of
Mm.
her gastrointestinal infections, and we really needed to decide if it was beneficial for her to receive antibiotics or to be admitted. Okay, but after we received the results, a lot of that was easy decision making.
Yep. So it definitely helped in terms of decision making. And as you said, like because you were getting those results in the emergency department, you knew exactly where to put the patient.
That's correct.
Yep. No, that sounds like there was a good outcome. So let's move on to our second case. So we now have Juan, who is a 4-year-old who lives at home with the grandparents and parents. And Juan suddenly has a fever of up to 38.7, also associated with abdominal pain and diarrhea. Apparently, he has been going to the toilet 4 to 5 times a day. And Juan's parents take him to the local hospital where he's diagnosed with an acute gastroenteritis. So, in terms of his treatment, he's given again antipyretics, something to treat the abdominal pain and also the diarrhea. So a few days pass and Juan is eating poorly with little to no appetite and his general condition is deteriorating. He revisits the local hospital and at this point he's given intravenous fluids for dehydration. But worryingly, because he's still unwell, he's advised to present to a tertiary hospital because he is anuric and he's dehydrated and lethargic. Clearly, he's deteriorating. And so, if you're working within this emergency department, I guess think about what tools you have at your disposal and how soon you have to act. So, I'm now going to turn back to Dr. Kang, and if you could let us know, I guess, what you found and perhaps what you were worried about in this particular boy.
Okay, so in this particular case, the patient's condition was deteriorating fast, and also he showed signs of severe dehydration to the point where anyone could suspect an acute kidney injury. And so rather than doing massive hydration for his severe dehydration, we wanted to immediately undergo blood testing. And what we did was, after history taking and physical examination, to find the fever focus, we considered acute gastroenteritis with severe dehydration. So we underwent a complete blood cell count. We did acute inflammatory markers. We checked the electrolyte panel and the kidney panel, including BUN and creatinine, to calculate his eGFR. And furthermore, because the patient had moderate to severe diarrhea, he was also given a stool exam, including the syndromic panel.
Mm. And so, what did you find on some of these investigations? What were the what were the things that jumped out at you?
Okay, so when we received this laboratory results, we were really alarmed because um, like we suspected, he had low sodium levels, high potassium levels, and low chloride levels, which show, dehydration. But also, we found that his BUN levels were 103.6 milligrams per deciliter, and his creatinine was 4.78 milligrams per deciliter. And so we used this to calculate his EGFR, which was 9, which is extremely low, considered stage 3 acute kidney injury. So that was really alarming. And furthermore, we also found that in his CBC, he had a very low hemoglobin count of 9 grams per deciliter, and he also had thrombocytopenia with a platelet count of 40K.
Okay, wow. Okay, so there was a lot happening. And so what was your concern here? What was the diagnosis?
Okay, so at this point, the patient was suspected of hemolytic uremic syndrome, and with the patient's history, together with the timeline of the symptoms of his progression, it suggested D positive HUS. And, there are many other causes of HUS, but because he had diarrhea, the most suspected diagnosis was D positive HUS.
And so with your tests, were you able to find out what the etiology was for his hemolytic uremic syndrome?
Yes. Thankfully, as soon as the patient arrives at our hospital, he was able to pass his stool. And so we collected his stool and we sent it to the lab. And immediately, within 3 hours after stool collection, his syndromic panel results were reported, and they showed positive for Shiga toxin producing E. coli, or STEC, which is one of the main causes of D plus HUS.
Yeah. And so what was the outcome for this patient? How was he managed?
Okay, so the patient was immediately transferred to the pediatric ICU and was isolated and placed on continuous renal replacement therapy. And because we were able to intervene really quickly, his clinical status improved, and he was discharged much later, but was discharged without major complications, and we saw a complete recovery of his kidney injury, which was really great.
That's fantastic. Yeah. And so I guess in this particular case, how did syndromic testing allow, like, how did it improve his outcomes, or how do you think it contributed to better outcomes or better, even better treatment for him?
Mhm. Okay, so like I said in the previous case, the rapid turnaround time was definitely um, an advantage of this test and
Mhm.
completely benefited this patient. But also,
Yeah.
I think that um, when choosing to do the syndromic testing, it is important to choose the right patient and choose the right time for specimen collection. In this case, the patient had diarrhea from day 1 to day 5, and this test went out on day 5 to day 6, around that time frame. And we know that, for HUS, it usually occurs on starting from, day 6 to day 7, after diarrhea begins. So it's not, it usually comes, post diarrhea. So had we, tested too late, had we given him the syndromic panel, a few days later, it might not have come out positive for the STEC. So
Yeah.
I think, that's one key finding of this case. So just, choose the right timing to do the test. And furthermore, it's easy to, just test every patient that has acute diarrhea, but we've
Yeah.
learned that it is only beneficial to those with, moderate to severe symptoms or, complications of diarrhea, because most diarrheal infectious diseases are self-limited, they don't need
Yeah.
antibiotics. So choosing the right patient would be the most beneficial. So I think this case really shows, that the benefit of this test was based on choosing the right patient, choosing the right sample, collecting it at the right
Yeah.
time.
Yeah, no, that's fantastic. That's some really good lessons from that. And so going into sort of syndromic testing further, so you've talked about some benefits. So rapid turnaround time, obviously it was highly sensitive, and you were able to make the diagnosis. Are there any other strengths um, that you find using the syndromic testing?
I think a benefit would be, patient isolation if they have
Yeah.
diarrheal diseases, that is very transmissible, such as rotavirus or norovirus, also
Of course.
SCEC, or just typhoidal salmonella would probably be a case that we need to isolate. So knowing it in advance, before we admit the patient, we can isolate the patient. So definitely that would be a benefit. Second would be, I think that we've been able to really reduce the amount of antibiotics administered to
Yeah.
patients, just because, a lot of children, when they are dehydrated, they seem very ill, and a lot of clinicians would want to administer antibiotics, but, by detecting a parasite or a virus, rather than a bacteria, that would, go into decision making to prescribe antibiotics. So those would be some of the strengths
Yeah.
of the syndromic testing.
That's great. So also has an antimicrobial stewardship sort of positive to it. So that's
Yes.
always helpful.
That's right.
And what about challenges or weaknesses with syndromic testing? Anything that sort of comes to mind for these cases or in other cases that you've used this?
Okay, so this is a very important and good question because, we've had a lot of experience with syndromic testing, but usually the strengths are highlighted, but there are challenges to using this panel, and they could include, it's difficult to differentiate between past infections compared to recent infections, and just interpreting whether, the identified pathogen is really the cause of the present fever or the present diarrhea. And
Yeah.
secondly, I think that, a lot of these tests, because there's just a variety of pathogens that are tested, sometimes there's multiple pathogens detected. And to interpret that and to see, which one is the cause of diarrhea it needs a lot of, consideration. And so those two would definitely be some of the challenges that we've been having using the syndromic panel.
Yeah, I can imagine some of the conversations with parents become a bit more clouded when you're saying, "Oh, we've
Hmm.
picked up 3 pathogens
That's right.
and it means the following," or it doesn't mean, this is
Mhm.
significant or it's not significant. So it makes it, yeah, you're right.
Yes,
The fact that it's so sensitive can make it a bit more challenging.
that's
And
right.
what about ethical considerations? Anything that you think from an ethical perspective?
Okay, so ethical perspective, I think the cost benefit would definitely be one, because I
Yeah.
think it's different in each hospital and in each country, but in Korea
Yes.
it's not insured, so the cost is very
Okay.
high for the parents, and we need to have uh, evidence-based decision making when to prescribe these panels, because for the
Mm,
parents who are paying for these expensive tests, we need to know if it's really beneficial for them, if it's not, that sort
yeah.
of thing. And also, like you just said, explaining to the parents, a lot of times if the clinician doesn't have a lot of education on these panels, then it would be
Yes.
difficult to interpret multiple pathogens. And, it could be, told to the patients that, there's a lot of different pathogens that are detected, which are causing, diarrhea to
Yeah.
your children, like wrong explanation, or explanation that is not, correct, would be another ethical consideration.
Yeah, absolutely.
Hmm.
Because I can imagine it would make it very difficult to explain to a parent why you didn't need antibiotic for a
That's
certain
right.
pathogen that
That's
was
right.
detected. Yeah. Yeah, absolutely. And coming back to your first point, I find that really interesting because obviously different healthcare systems around the world are different in terms of who pays for testing,
Hmm.
whether it's covered
That's
by their
right.
hospital admission. So it sounds like in Korea, what you're saying is that patient or parents pay for the tests that you order.
Hmm.
And
That's
there's
correct.
almost a bigger impetus from you as the clinician to use that evidence base to carefully select, as you said,
Hmm.
who would benefit from testing.
That's correct. That is correct.
I like that. I think that in some ways, I know it's the best way to determine which tests you should and shouldn't order, but I think an evidence base is always helpful.
Hmm.
And weighing up that cost benefit is obviously very important there as well, particularly
That's right.
for the parents and the patients. Yeah,
Hmm.
no, I love that. Thank you. And in terms of any other sort of lessons or things that you wanted to share with our listeners?
Just that, syndromic panel, it's very beneficial with by using it with a lot of diagnostic stewardship. And I don't know if that makes sense, but I would like all clinicians to, have the benefit of it without, causing harm or too much, cost for the patient. And I think that would definitely help
Yeah.
in, decision making.
No, that's great. Thank you. My other question for you is, how do you explain to parents what the difference between this syndromic testing is and a standard culture-based method of testing?
So, I would usually tell the parents that the culture is gold standard for bacterial pathogens, and to identify whether it is the current cause of the fever or diarrhea in the patient's case. However, it has a very low yield, very long turnaround time. And so in order to overcome that sort of limitations, we use the syndromic panel, which can test not only bacterial pathogens, but viral and parasitic pathogens, that has high sensitivity and rapid turnaround time. However, we're just testing for the presence of the pathogen. We're not testing whether it's viable. And so it takes a lot of, interpretation is very important
Yes.
in, after receiving the results of the syndromic testing. And that's how I usually explain it to the parents.
That's fantastic. Thank you. That's really helpful. Dr. Kang, where can our listeners keep up with your research and the work that you're doing?
Okay, so you could follow me at the Google Scholars list of articles. I usually post my
Great.
research there.
Amazing. We'll be sure to tune into that and add you on our Google Scholar. All right. Well, thank you so much for your time today. We really appreciate your contributions to our podcast, and hopefully listeners, just like I did, learn a lot from your experience. Thank you so much.
Thank you so much for having me. It was a pleasure.
So Alicia, when I was discussing with Dr. Kang, I think one of the highlights for me was that with gastro illnesses, as we all know, they can be really non-specific, but they can be as serious as hemolytic uremic syndrome. And so what I got out of this was, I guess, the value in syndromic testing and being able to test for all these different gastrointestinal pathogens, and therefore sort of having, being a clinician and being able to respond accordingly with that additional and very quick turnaround information.
Linny, I think it is wonderful that we have gotten to this stage. As you said, to have this type of testing that gives us very quick information and information that really matters and that will give us kind of a perspective on how the patient may evolve depending on the pathogen that we have results back on. So it will be quite different treating a gastrointestinal illness that is caused by a norovirus versus salmonella, for example.
Yeah.
So
Right. I was going to say it always comes back to that point around antimicrobial stewardship again, just being able to say, yes, in this instance, antibiotics may be useful versus a viral illness where you just need to let it run its course.
correct. I think it is wonderful that now we have the tools to actually prove what we suspected in the past, that not all kids needed antibiotics for all gastrointestinal diseases. And also parasitic diseases. I mean, there are countries where, of course, therapy applies for parasites, but not every gastrointestinal illness is caused by a parasite and forcefully will need antiparasitic medication. Would you agree?
Yeah, absolutely agree. And also, I think when it comes to parasitic illnesses as well, it depends on the experience and the technical skills of the person looking under the microscope. So having a PCR test for parasites is a huge advantage.
Absolutely. It has changed things. It's a different game nowadays for us, which is wonderful.
Yep, totally. Game changer.
For more information on gastrointestinal infections and syndromic testing, visit the Global e-Learning portal on the WSPID website, your hub for pediatric infectious diseases insight.
And that's the end of today's episode. We just wanted to say a big thank you to our esteemed guest, Dr. Hyun Mi Kang. We really hope these cases and our discussion have highlighted the ways in which syndromic testing has changed how we practice medicine.
Whether you're on your way to or from work, out for some daily exercise, or doing the school pickup, thank you for listening to the Syndromic Insights podcast. Make sure you're subscribed on your favorite podcast platform so you don't miss an episode. Please share the podcast with your colleagues, leave us a review, and be sure to tune in next time.